Hello, this is thrombocyte disease tutorial presented by the SchrDbb reference, Color Atlas of Hematology by Harald Thelm. So you're going to see thrombocyte abnormality. So we start with thrombocytopenia, which just means low level of thrombocyte. So we can have thrombocytopenia, which is due to increased demand. That's from a high turnover. Is it correct? When there's a high breakdown of the thrombocyte, you have thrombocytopenia. The next one, so it is a characteristic sign of a pathology that can be among the few thrombocytes seen in the blood smear. So the bone marrow in this thrombocytopenia show a raised or at least a normal megakaryocyte count, yet too there may be an increased presence of less mature form. Now the next one, you have a drug-induced immunothrombocytopenia. So if you have a drug-induced immunothrombocytopenia, it can also result to a thrombocytopenia. So how does this result to a thrombocytopenia? A drug-induced immunothrombocytopenia occurs when you have a drug that is going to result to an autoimmune reaction that is going to affect the thrombocyte, that's going to result to a low level of thrombocyte. Is it clear? So still in this case, you're going to have high level of megakaryocytes at the level of the bone marrow. So those are the different cases. Now we continue with the next case of thrombocytopenia. So as you can see, these are the forms of thrombocytopenia. A, this blood smear show a normal size. You can see normal size density of the thrombocytes, as you can see. And now in diagram B, in this blood smear, the thrombocyte density is lower size has increased, feature typically of immunocytopenia. So here in diagram A to diagram B, in this blood smear, the thrombocyte density is lower as compared to the diagram A and has increased. So the density of the thrombocyte is lower. So you see that there is no thrombocytes as compared to this case where you have normal size and density of the thrombocyte. Is it clear? So you have a low density of the thrombocyte and you also see the increased size of the thrombocytes. It may make you think of a feature of an thrombocytopenia. Now, what are the most common triggers of drug-induced immunothrombocytopenia? The first one, you have analgesics. So the second one, you have antibiotics. The third one, you have anticonvulsants. The fourth one, you have arsenics, you have quinidine. So analgesics, antibiotics, anticonvulsants, arsenics, quinidine, quinine, digitalis, preparation, furosemide, and all these drugs are involved as trigger with immunothrombocytopenia. Now another form is idiopathic immunothrombocytopenia. The name is largely historical because often no trigger is found. So here it can also be, so here you can think that the trigger may be post-infectious and acute form, or it can be an essential thrombocytopenia where you have a thrombocytopenic purpura. So those are the cases where they are idiopathic. Another case is a secondary immunothrombocytopenia. So in the case of a lupus erythematosus, so other forms are immune vasculitis, lymphoma, and tuberculosis. Those are secondary immunothrombocytopenia, where in the case of a systemic lupus erythematosus, you are going to have what? You have antibodies that are going to be targeted against the thrombocytes, resulting to an immunothrombocytopenia. In case of an vasculitis, also antibodies are going to be targeted against the thrombocyte. And you have lymphoma and tuberculosis the same. You have post-transfusion purpura. So it occurs mostly in women about 1 week after the blood transfusion and often after earlier transfusion or pregnancy. So when you have a post-transfusion purpura, why? Because here you have, in a post-transfusion purpura, you're going to have a post-transfusion thrombocytopenia. Is it clear? Because there are certain antibodies which are present in the donor's blood that are going to react with the platelets in the recipient's blood and result to a low level of thrombocyte. Is it clear? So that's why it's called a post-transfusion purpura. We have thrombocytopenia in microangiopathy. Can have also thrombocytopenia when you have microangiopathy. So in microangiopathy is when you have red blood cells are going to collide with the blood vessels which are normal and which are reduced in size, like in the case of atherosclerosis. Basically, this group includes a thrombocytopenic it includes a thrombotic thrombocytopenic purpura and a disseminated intravascular coagulopathy. Here, you need to know that what in microangiopathy we have colliding of the red blood cell with the small or unrigid blood vessels. So when it collides, it's going to cause micro lesion, micro tear at the level of the blood vessels. When you have micro tear at the level of the blood vessels, now the thrombocytes are going to try to close up those micro tears. Is it clear? So when the thrombocytes close up those micro tears, you are having now you are going to have now low level of thrombocytes, resulting in thrombocytopenic purpura. Now the next disease, you're going to have a thrombocytopenia in hypersplenism. When you have when you have a high functional spleen, you're going to have a destruction of the thrombocyte. Now this diagram now here is going to still continue with thrombocytopenia. Down diagram C is a pseudo thrombocytopenia. Is it clear? So a pseudo thrombocytopenia, here the thrombocytes are not lying free but they are scattered around. So a pseudo thrombocytopenia, you have what the thrombocytes are going to be highly agglomerated, are going to at a certain position that make you think that the thrombocyte level density is going to be reduced, but it's not actually quite reduced. That's why it's called thrombocytopenia. Now the diagram D, you have a giant bluish inclusion arrow. So you have giant bluish inclusion arrow. So is it clear? So that's one as a large as an erythrocyte in thrombocytopenia. So this is a dull type bluish inclusion in normally granulated segmented neutrophilic granulocyte. Is it clear? It is called the May-Higlin anomaly. Now the diagram E is going to show large thrombocytes. As you can see here, the first diagram, you have large thrombocytes in thrombocytopenia. Now we have also diagram 2, which shows a thrombocyte-like fragments from destroyed granulocytes. Is it clear? So we have which have the same structure as the staining characteristic of cytoplasm of the granulocytes, band cells. And diagram 3 shows a clinical status of sepsis in disseminated intravascular coagulopathy in automated counter cytoplasmic fragment and included as thrombocyte fraction. Actually, here you have a patient that has a severe infection, and that severe infection, you have granulocytic inclusions that are going to increase in number, and you have also fragments of granulocytes that are produced. Those fragments of granulocytes may represent like thrombocyte, but you have low level of thrombocyte because in disseminated coagulopathy, you're going to have blood clots that are going to be formed at the level of many vasculatures, basically in order to prevent the spread of the bacteria from one locality to another, basically. Now the next one is thrombocytopenia due to reduced cell production. That is at the level of the bone marrow. Basically, you can have the different causes like a chronic alcoholism. Basically, you are going to have low level of folic acid. You have folic acid deficiency. You have chemical and radiology causes, which is going to affect the myocardial at the level like the bone marrow. You have viruses affecting. So, like in the case of Epstein-Barr viruses causing mononucleosis. You have measles. You have influenza virus. You have cytomegalovirus. Influenza virus intrusion can result to a thrombocytopenia. You have the next one. You have neoplastic and aplastic bone marrow disease. So is it clear? So now the neoplastic bone marrow disease can be due to a leukemia, it can be due to a lymphoma or plasmacytoma, due to an infiltration due to a bone marrow cancer. Now it can also be so when you have a myelodysplasia, so you have hypertrophy of the thrombocytes of the myocardial site, but you have low level of the thrombocytes, myelodysplasia. You can have a progressive thrombocytopenia. That's a pan-myelocytosis, or you can have also an aplastic anemia. Now, vitamin deficiency, like in the folic acid deficiency, vitamin B12 deficiency are required for thrombocyte production. If they are deficient, they are going to also result to thrombocytopenia from the bone marrow. Now, we have constitutional disease and amegakaryocytic thrombocytopenia without any of the above causes. So, if you have no causes above and you have an amegakaryocytic, means that what it means that you don't have megakaryocytes and you have a thrombocytopenia. Is it clear? It's usually rare. Is it clear? It is seen in children with congenital radial aplasia. So when you have an aplasia, congenital aplasia, you can result to that. Is it clear? So you have different cases of congenital aplasia, like in the Wiskott-Ulrich syndrome, where you have a thrombocytopenia and you have immune deficiency and eczema is found. That is the syndrome that the patient has: thrombocytopenia plus immune deficiency plus eczema. In case of an X chromosomal recessive disease in boys and present with a thrombocytopenia with ineffective megalocytomegakaryopoiesis. Is it clear? Now we also have another one which is called the May-Heglin anomaly. It's a dominant hereditary transmission and is characterized by thrombocytopenia with giant thrombocytes and the granulocyte inclusions. We also have granulocyte inclusions present here, which resemble the dull bodies. So that is May-Heglin anomaly. We have granulocyte inclusion that resemble the dull bodies and also have giant thrombocytes present. Is it clear? So those dull bodies resemble like endoplasmic reticulum aggregates. Is it clear? So this is the morphology of the thrombocyte and megakaryocyte. So in bone marrow, in thrombocytopenia due to increased turnover. So this is the bone marrow. When you have increased turnover, we see the megakaryocyte number is going to be normal or increased. So due to increased turnover. In diagram B, we have thrombocytopenia against a background of myelodysplasia. In the case of a myelodysplasia, you have hyperplasia of the cells, but you have a thrombocytopenia. Is it clear? Now the next one is diagram C to F. Now so diagram C to F is in myelodysplasia. So all this is going to be myelodysplasia. Now in diagram D, particularly C and D, you have an acute myeloid leukemia. So a leukemia that has occurred and result to thrombocytopenia. And diagram E and F, you have a bizarre anomaly. Is it clear? Of thrombocyte shape. So all that is involved here. So the next diagram, the next disease is going to be thrombocytosis, including essential thrombocytopenia. And essential thrombocytopenia is usually an idiopathic thrombocytopenia. Is it clear? So in this case, this is essential. This is thrombocytosis. So increased level of thrombocytes. Now in case of essential thrombocytopenia. So in case of a reactive thrombocytopenia, this is a term which is a constant elevation of thrombocytes counts above the upper limit range of 300 to 450 cells per microliter, 50,000 cells per microliter, may be reactive. So it may be in response to various tumors or any disorder. You have a reactive thrombocytopenia, a thrombocytosis. A reactive thrombocytosis is because of the secondary cause that you have a reactive thrombocytosis. You can identify the cause that made the increased level of thrombocytes. But now, in case where you have an essential thrombocytopenia, in contrast, is a myeloproliferative disease in which the main feature increased thrombocytopenia is accompanied by other signs of group of the disease. So this is a myeloproliferative disease where you have the thrombocyte level are going to increase at the level of the bone marrow. That's essential thrombocytemia. So severe thrombocytemia may also be seen in osteomyelosclerosis, polycythemia vera, chronic myeloid leukemia, and all the forms. Now, we have diagnostic criteria of essential thrombocytopenia. So you have different diagnostic criteria. Now the first one is that the thrombocyte level should be greater than 600,000 times 10 to the power 9 per liters. The normal erythrocyte level should be less than 18.5 gram per deciliter, because if the erythrocyte level is greater than 18.5 gram per deciliter, you may think of polycythemia vera as being a differential. No significant bone marrow fibrosis, because if there is significant bone marrow fibrosis, it means that the differential of essential osteocytopenia of essential thrombocytosis is going to be osteomyelosclerosis. There should be no splenomegaly. There should be no local erythroblasts in the complete blood count. There should be absence of morphologic and cytologic criteria of myelodysplasia, and there should be secondary thrombocytosis, that's iron deficiency, inflammation, neoplasia, trauma. So there should be no secondary thrombocyte, because secondary thrombocytosis is more like a reactive thrombocytosis. So those are large thrombocytes are found at the peripheral blood smear in the case of essential thrombocytosis. So this is a peripheral blood smear. So this is diagram C. The first is essential thrombocytopenia. So A, you are going to see increased thrombocyte level. That's thrombocytosis. That's how thrombocytosis is example. You have increased thrombocyte level density. Is it clear? Now diagram B, you have large thrombocyte. So diagram B, in diagram B here, you have a very large thrombocytes at this level that you can visualize. Now in diagram C and D is the bone marrow cytology. In essential thrombocytemia, there is a striking abundance of very large and hyperlobulated megakaryocytes. Is it clear? In diagram C. Is it clear? Now such megakaryocytes may also be seen in polycythemia vera. Is it clear? But in polycythemia vera, is all the cell series that is going to be increased. Now the next one is size comparison with a basophilic erythroblast. You see, this is a basophilic erythroblast, this is megakaryocyte. You see how they are compared. For the megakaryocyte, is going to be very large compared to that in the case of a thrombocytosis. So from here we have visualized every disease in the thrombocyte abnormalities, and you can say thanks for your kind attention. Please don't forget to like and subscribe for our channel. Thank you.